Obesity-related cancer mortality is not evenly distributed across the population. Black and Native American communities suffer disproportionately high death rates, and this disparity cannot be explained by biology alone. Instead, it reflects deep and enduring social and structural inequities that shape nearly every aspect of health, where people live, what they eat, the care they can access, and how they are treated within the medical system. These disparities are not just unfortunate. They are the predictable outcomes of long-standing systemic neglect. In both Black and Native American populations, higher obesity prevalence is a major driver of increased cancer risk. But obesity itself is deeply influenced by social determinants: poverty, food insecurity, neighborhood safety, education, and access to preventive care. In many communities of color, fresh and nutritious foods are scarce, replaced by ultra-processed, calorie-dense options. Physical activity is limited not by lack of will, but by unsafe streets, inadequate green spaces, or a simple lack of time for those working multiple jobs. These conditions make healthy weight maintenance a steep uphill battle. When it comes to cancer detection and treatment, the inequities widen further. Black and Native American individuals are less likely to receive routine screenings, such as mammograms, colonoscopies, or pap tests, even when guidelines recommend them. They are more likely to be diagnosed at later stages, when cancers are harder to treat and survival odds are lower. Delays in diagnosis often stem from systemic barriers: lack of insurance, limited transportation, understaffed clinics, and implicit bias in healthcare settings. The result is that by the time care is accessed, options are fewer, costs are higher, and outcomes are worse. Even within the healthcare system, disparities persist. Studies have repeatedly shown that Black and Native American patients often receive less aggressive treatment, experience longer wait times, and report lower levels of trust in medical providers. These patterns are not isolated incidents. They're symptoms of a system that too often fails to treat all patients equitably. Cultural misunderstandings, communication gaps, and outright discrimination all erode the quality of care, leading to worse outcomes even when controlling for stage of cancer or other clinical factors. The psychological toll cannot be overlooked. Generations of marginalization and medical mistrust make it harder for individuals to engage fully with the healthcare system, particularly when they have already experienced neglect or disrespect. This is not simply about individual choices. It is about the cumulative effects of structural violence that leave certain populations more exposed, more burdened, and more vulnerable to diseases that should be preventable or treatable. Cancer is not a disease that develops in a vacuum. Its roots lie in decades of policy decisions, economic disinvestment, and social exclusion. If we ignore the racial and ethnic disparities in obesity-related cancer mortality, we are accepting a system that treats some lives as more valuable than others. This is not just a matter of public health. It is a moral failure. Addressing these disparities will require more than awareness. It demands bold action to dismantle the inequities embedded in housing, education, employment, healthcare access, and food systems. Without systemic reform, the trend will not reverse. More Black and Native American individuals will continue to die from cancers that might have been prevented or cured if only they had been diagnosed earlier, treated more aggressively, or given the same chances as others. The statistics may be stark, but the human cost is far worse. Families devastated, communities diminished, and trust in the healthcare system further eroded. Until these disparities are addressed head-on, cancer outcomes will remain deeply unequal and unjust.